Hello, 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 hello. Ravi, your voice audible இருக்கா? 6:45 தான் ஸ்டார்ட் பண்றோம். ஜஸ்ட் வாய்ஸ் ஆடிபிளா இருக்கான்னு பாருங்க ரவி. ரவி வாய்ஸ் ஆடிபிளா இருக்கா? ப்ராப்ளம் எதுவும் இல்லைல்ல? ஓகே, வாய்ஸ் கிளியர் தானே? ஓகே, ஓகே, ஃபைன், ஃபைன். சரி. வால்யூமா இன்னும் அதிகமாவா? தெரியலையே. இல்ல இல்ல செஷன் ஓகே செஷன் எண்ட் பண்ணல. இப்போ கொஞ்சம் கிளியரா இருக்கா இல்ல இப்பயும் அப்படியே தான் இருக்கா? இருங்க, நான் வேணா வேற வேற ப்ளூடூத் கனெக்ட் பண்ணி பார்க்குறேன். ஓகே, பாருங்க வாய்ஸ் ஓகேவா? இதுலயே கண்டினியூ பண்ணிட்டோமா இல்ல வேற ஏதாவது ஹெட்செட் மாத்தணுமான்னு பாத்துக்கோங்க. சோ தட் நடுவுல டிஸ்டர்பன்ஸ் இருக்க கூடாது. அப்படியா? வால்யூம் ஃபுல்லா தான் இருக்கு. இவ்வளவுதான் வருது வால்யூம். இவ்வளவுதான் வால்யூம் வருது. இதுலயும் ஃபுல்லா இருக்கு. ஹெட்ஃபோன்ஸ் இதுலயும் 100% இருக்குப்பா. இருங்க இருங்க அப்படியே இருங்க அப்படியே இருங்க. இப்ப செக் பண்ணுங்க. இப்ப கரெக்டா இருக்கா? இப்ப வாய்ஸ் எப்படி இருக்கு? ஹலோ, இப்ப 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 எப்படி கேக்குது? இப்ப ஃபர்ஸ்ட்டுக்கு பெட்டரா இருக்கா? இப்ப வாய்ஸ் குவாலிட்டி பெட்டரா இருக்கா? ஏன்னா அப்புறம் நடுவில் வந்து கேட்கலன்னு ஸ்டூடெண்ட்ஸ்க்கு பிரச்சனை வரக்கூடாது, தான் கேட்குறேன். ஹலோ, இப்ப நல்லா இருக்கா? ஷூரா? ஓகே, ஃபைன், தேங்க்யூ தேங்க்யூ. ஓகே ஓகே, இருங்க லைன்லயே இருங்க. ரைட் ரைட் ரைட், தேங்க்யூ தேங்க்யூ. So 6:45 we will start. So meanwhile, whoever have joined, you can give your introduction over here in the chat box available. Then we will go to the lecture. Okay, we will go and see very interesting, important topics in the field of pulmonology. Okay, right. So meanwhile, you can give your introduction here in the chat box. Okay, we will start very soon. Okay, in 5-10 minutes. All be very active so that in between, if I ask questions, be very fast to put your answers here, so that it will be more interesting. Okay, and it will be even motivating me also to say more and more points. Still 10 minutes we can wait here. 6:45 now, so another 5 minutes, then we will enter to the session. Okay, in 10 minutes, the persons who have joined, 37 people have joined. You can post your doubts. Okay, in this 10 minutes, before others join. Okay, if any doubts you have got, you can post so that I can clear from my aspect. 10 minutes we no need to waste. If you got some doubts, you can post. Okay, first somebody has asked a question. Is pulmonology a relaxed lifestyle branch? We can't say it is relaxed. Okay, we can say it depends on your interest. Okay, it is not relaxed. Okay, it depends on your interest. Emergency cases are definitely there. Example: foreign body removal, tension pneumothorax, ARDS, pulmonary embolism. Everything is an emergency case in cases of pulmonology. So definitely it is not a very relaxed branch, especially acute exacerbation of asthma, acute exacerbations of COPD. All these are emergency cases. So you can't consider it as a relaxed branch like some dermatology. Okay, definitely emergency cases are there. It is equal. It is like a specialization, just like cardiology. Pulmonology is one of the important specialization. You people would have understood the importance of this specialization after where after this corona, right? Everywhere in every debate you can see a lung doctor has been called, a pulmonologist is called, because it is a disease of the respiratory. So most of the acute infections, epidemics, pandemics, if you see all those things, most of the things will be affecting the respiratory. Breathing trouble will be the main complaint. So definitely it is not a relaxing branch and all. It is very interesting branch, very challenging branch, and you can feel the pleasure, okay, when the patient comes out. Okay, any other question? The same person have asked, you have some Nazi symbol on your wall. Actually, this room is a common room. It's not my own room. Okay, it's a common room belonging to our place. Okay, so I don't know what symbol they have kept. Okay, so no need to comment on those things. Then fine. Another 2 minutes. Then we will start. Okay. Any other questions somebody want to ask? You can ask. Then otherwise we can start. Because the time we gave was 6:45. I came a bit early because to just check the voice quality and to see the technical issues. Because when we come late and it becomes late, so that's the reason I came very early. Okay, Snehita, any particular session you're gonna? No, it's not like that. Any particular session. This session is about the introduction. Okay, very important introduction about the symptomatology of the pulmonology. Okay, to approach these cases. Okay, so these are the points which we will discuss today, and separate topics. I think a list is there. We will be covering all the exam cases separately in the forthcoming session. Yeah, all RS cases definitely, Lakshmi. All respiratory cases I will be covering, no doubt in that, but not in this one session. Okay, in 1 hour. See, very important thing is that even though if you go very fast touching the concepts, we need certain time. Okay, we can't conquer all the knowledge in one sitting. If you do like that, you will not understand. If you see my teaser video, you would have understood. I said how important is to understand the clinical medicine, how important is to take the inside the clinical medicine and develop your own concepts to come to a higher level, right? So please let us go session by session. Okay, in clinical pulmonology, it will be useful. It's 6:40, 6:45. We have to start. I think. Right, we will start with slowly with basic introductions. Okay, because already 70 people, few people have joined. Right, we will start with the basic introduction. First of all, I am Dr. Sabrina Ravichander. Okay, I am a consultant pulmonologist. I am finished my MBBS, MD, everything in a government medical college. Okay, then I also finished my MRCP in respiratory medicine from London. Then also I'm also a diplomat in European Respiratory Society, DNB Respiratory Medicine. Theory exam I have cleared. Practical because of this corona they have not kept, so I have to finish that also. So DM also I'm taking classes, but DM I'm not interested to do DM because there is no big change between this and the DM. That's the reason. Okay, already what I'm going to do in DM I'm doing now itself. Okay, so this is about me. Then I'm as an assistant professor at Balaji Medical College and consultant at Rela Hospitals. So as I said, I would like to thank IMA MSN for conducting this live session to the undergraduate students, because the clinical part is very important. Okay, and during this lockdown period, you people have got a chance to interact with the specialist, and the clinical medicine is such important, and in that I am a part, in that I am taking care of these two important organs. Okay, so if you, even if you see my book, too much echo, is it so? I'm using headphones only. Yes. Are you able to hear me? Any problem in the audio? I just checked the audio. All said it is fine. Is there any problem? Can anybody respond? Is there any problem in my audio? Is there any problem in my audio? Hello? Audio is clear, right? Then somebody is confusing me in between. Fine. Right. Okay. So what I want to say is that this is the importance of this session, and very importantly, everybody say they keep their loved ones in the heart. Okay, but I, in my book itself, I have written, all say that keep their loved ones in heart, but I keep my loved ones in my lungs. Okay, so and because what to say, that much is the love to pulmonology I have. Okay, so general medicine I really liked it, but when it came to the RS part, then it totally deviated, and I liked RS like anything. Okay, respiratory like anything. Okay, so I'm just here to share my experience in this respiratory medicine. Okay, and IMA MSN has done a beautiful job to share my feelings to you people. Okay, and you people can get lot of knowledge, and you people can post your doubts. Okay, regarding the subject. Fine. We will start the session now. Right. Now let us take it very interesting. Let us take it very interesting. All be ready in the live chat box. Whenever I'm asking a question, you all must be boosted. Don't be just simply sitting in the home watching TV and just hearing it by one headset. Come to a separate room. Watch our lectures very clearly and very interestingly, and have an active discussion. Whenever I'm throwing one question, you people have to immediately answer it, and I'm going to watch that answer and reply to you. So it's going to happen like a live class. Clear? Okay, so that is very important. All be very active. Okay, let the spirit be high. Okay, and let us rock. Okay, right. Fine. So when a respiratory patient comes, okay, when a respiratory case comes, problem is, first of all, we should know certain basics. We should know certain basics. What are the certain basics I'm saying is that, okay, when a respiratory case comes, when I see an house surgeon who is seeing the case, what he is doing now, what problem we're having? Cough. Okay, then what problem? Breathing trouble. Fine. Okay, then he's coming and presenting the case. Sir, this patient came with cough and breathing trouble. That's it. I said, say further. That's it. Okay, what do you know? What do you know? What do you come to know from this? Sir, some problem, sir. Some problem? What problem? Sir, respiratory problem. What respiratory problem? Don't know. What are you going to give? We'll give some cough syrup, sir. Fine. This is the knowledge. For this reason, are we reading MBBS? No, my friends. Okay, no, not at all. So, what I want you to say is, when a patient of respiratory comes, you people must know following things. What you should know? You people should be able to recognize what is the anatomical diagnosis. Number two, what is the pathological diagnosis? Number three, what is the etiological diagnosis? For these three things only, you are going to ask history to the patient. You are going to examine the patient for knowing these three things only. What? Anatomical, pathological, etiological. What is this anatomical? Example, the problem is there in the lung parenchyma. It is anatomy. Problem is there in the pleura. Anatomy. Problem is there in the trachea and bronchus. Anatomy. Problem is there in the upper respiratory tract. Anatomy. This is anatomical diagnosis. Are you understanding? Very clear why this is important. Suppose a patient is having cough because of a big pleural effusion, and in that, if you give a cough syrup, will it work? No, it will not work. Are you understanding? Are you understanding? It will not work. So it is very important to localize where is the anatomical problem. Okay, if the problem is there in the parenchyma and you are going to put a needle and try to take something, will it work? Patient will die in pneumothorax. Are you understanding? So please make an anatomical diagnosis. That is your first goal. You have to set the goals. Number one. Second goal, what? The pathological. Pathological means what? Whether it is a consolidation, or whether it is a cavity, or whether it is a fibrosis, whether it is a calcification, whether it is a collapse, okay, whether it is a mass. So these are all called as what? These are all called as what? The pathological diagnosis. Okay. So our goal should be make an anatomical diagnosis, pathological diagnosis. Third, what is the third? Etiological diagnosis. Okay, suppose this is a case of an cavity. What could be the etiology? By based on your history, you must able to come to the etiology. What could be the etiology? Whether it is an tuberculosis or whether it is an bacteria or whether it is an malignancy or something like that, you have to come to an etiological diagnosis. Are you understanding? So our main goal before seeing a patient is three important things. What are those three important things? Number one, make an anatomical diagnosis, make an pathological diagnosis, make an etiological diagnosis. There comes a proper diagnosis. For making these three diagnoses, what is the required for you people to do? You people should be very good in history taking and clinical examination. Are you understanding? Even now in my OP, when I'm sitting and seeing patients in my OPD, when a patient comes with complaints of cough, breathlessness, my entire brain will be working on which part of the lung is involved, or is it heart mimicking the lung, or is it upper respiratory mimicking the lung, or is it the gastro reflex mimicking the lung. So my entire mind will work on anatomy, pathology, etiology. When I come to this together and I put it in my mind, then I treat the patient according to the anatomy, pathology, and etiology. Patient will be 100% better. You mark and keep. Otherwise, if you are not going to define your case like this and simply are going to treat something, patient 100% will not like you. Are you understanding? Okay. So this is the first introduction. Okay. So okay, sir, what should I do to get this anatomy, pathology, and etiology? There only the lectures which I am going to take is going to help you. Okay, it will help you. Okay, and you can sharpen it further by knowing, by reading many other things also. Right? Understood? Okay. So now let's go to the introduction now. So when a patient is entering, I think already we all know, we ask some basic things like name, age, sex. Okay, we ask all these things. Okay, now my question shooting is starting now. Patient is of young age and is coming with respiratory problem. What respiratory condition do you people think? Answer. I will wait only for 20 seconds. Good. Fine. So many people are in favor of asthma, right? Many people are favor in asthma, some saying primary TB. Okay. Now here my answer. So definitely young age disease. What are the young age diseases? Means congenital diseases, right? There are many congenital diseases. Can you name some congenital genetic diseases? Have you heard about cystic fibrosis? Cystic fibrosis. Have you heard about congenital anomalies of the lung? Pulmonary hypoplasia, pulmonary aplasia. Okay, all these anomalies. Then even asthma, definitely it starts from a childhood asthma. It starts from the childhood time itself. Okay, recurrent infections, they are also more common in the younger age group. Okay, so these are all the young age diseases: asthma, congenital lung diseases, congenital syndromes like carcinogens and all these syndromes, cystic fibrosis, then asthma. All these things form a part in the younger age group. Fine. Similarly, old age. Okay, if the patient is old age, what are the lung diseases do you expect? Anybody? Young syndrome. Young syndrome, it comes in bronchiectasis, right? Then say any other in old age? Yes, very good, very good, very good. Everybody is answering correctly. COPD, malignancy, TB. Okay, somebody is answering emphysema. Please make one clarification. What is emphysema and what is COPD? COPD has got two phenotypes, right? Pathologically, one is emphysema and another is chronic bronchitis. Okay, so these are the two phenotypes. Okay, so don't confused between both. Answer is very correct. You people are saying malignancy. Lung cancers are more common in older age group because it's smoking related. They smoke for more than 30 pack years and they come for an lung cancers. Very similarly, chronic obstructive pulmonary disease, COPD, is again smoking related. It happens more in the older age group. Okay, very good, very good. Okay, so age importance you people understood. Okay, then sex. Now come, let's see how much is your knowledge. Name the diseases which affect only males. Lung diseases affecting male. Come on, keep it interesting. Don't feel bored. Keep it interesting. Lung disease which affects male. What? TB and carcinoma. Do you think cancer affects only male? Sarcoid, COPD, lung CA. No. Right answer. See, this is why doctor like pulmonologist experts are important. I agree. COPD, lung cancers, they are all more common in male, but they are not exclusive in male. Are you understanding? So male disease, one disease is there. Answer right and keep LCH, Langerhans cell histiocytosis. Langerhans cell histiocytosis. Please write and keep LCH. This is exclusively seen in males. Most of them will be a smoker, and these people will be having cystic lung disease, male disease. Okay, it's a male disease. Okay, right. Similarly, now, yes, very good, Langerhans. Snehita Manohar answered it correctly after a long time. Okay, now similarly, I'm asking you another question. Can you name one disease exclusively in female? Any one disease? Lung disease exclusive in female. Keep it interesting. Don't get bored. Come on, because we are simply really in home, right? SLE. Again, I'm saying Tejas, SLE is a connective tissue disorder which causes ILD. Agreed. More common in females. Agreed. But is it very specific, happening only in females? Not sarcoid. Come on. Yes, Abby Abraham has given the right answer. LAM, LAM. What is LAM? Lymphangioliomyomatosis of lung. Okay, lymphangioliomyomatosis of lung. Okay, so LAM, lymphangioliomyomatosis of lung. Okay, it is very exclusively seen in females. Okay, so I'm asking some exclusive diseases. Okay, so it's very exclusive in females. This LAMP, it causes a pulmonary proliferations of the muscle cells as well as the lymphatic system. So as a result, patients present with the multiple cysts in the lung and pleural effusions. Okay, so LAM is more commonly and exclusively seen in the females. Are you understanding? Okay. So this is the importance of the sex. Okay, and otherwise I agree to all your points. Okay, in generally in males, if you see, COPD is having more risk, lung cancers are having more risk. Similarly, in female, connective tissue disease like SLE, these diseases related ILDs are more common. Okay, male and female in young age, male is more common and female is less common. But whereas in older age, male and female asthma patients are they both are equal in incidence. So like that, we can keep on saying, but just remember LCH over here and LAM over here. And similarly, in female, some conditions are related to menstrual cycle. Okay, you call it as catamenial pneumothorax. Catamenial pneumothorax. Please write a note. Catamenial pneumothorax. It means when the patient is having, when a girl is having a menstruation, that time that she develops a pneumothorax. Okay, that is called catamenial pneumothorax. Okay, so similarly, there are many terms like catamenial hemoptysis. Okay, catamenial pneumothorax. So these are all are related to menstruation. Why in menstruation this should happen? There is an answer for that also. I will say you now itself, because of the pulmonary endometriosis. Because if you see the embryology back, uterus, lungs, all the organs come from the same embryology. Okay, so as a result, some uterus related tissues, okay, some uterus related endometrium will be left remnant in the lungs. So as a result, when the patient is going for menstruation, there will be also an endometrial proliferation relating to these problems, right? So this is called as a what to say, endometriosis of lung. Okay, so that is responsible for the catamenial type of things. So they are more exclusively seen in females. Understood? So name, age, sex. Then importance is occupation. Okay, as a pulmonologist, very importantly, we are giving a RS case to you. Please ask the occupation to the patient, because there is a term called as pneumoconiosis. There is a term called as pneumoconiosis. Pneumoconiosis is also called as occupational lung disease. Is also called as occupational lung disease. A big list is given in Fishman's textbooks of pulmonology. 100 to 200 types of occupational lung disease they have given, but very importantly, the examiner, they will ask for 4 or 5 diseases. So I'm going to just say that 4 or 5 diseases. They may ask you, if the patient is working in cotton factory, what it is called as. Your answer should be bicinosis. If the patient is working in a sugarcane factory, what it is called as bagasse. Okay, bagacesis. So similarly, most common occupational lung disease, what they will ask, answer is silicosis. If your patient is working in some shipbuilding, insulation factory, cement sheet factory, what it is called, what disease he has, there's chance of developing asbestosis. Silicosis, what are the occupation having the risk factor? Suppose your patient, you are a student of Rajasthan and your patient is working in some marble factory or some tiles factory of Rajasthan where he's doing continuous marble and tiles thing. Think how much silica crust he will get exposed to. So these occupations, stone grinders, stone cutters, then the similar that tile makers, tile cutters, all these occupations are having high sand blastings. Okay, all these occupations are having high risk of developing silicosis. So silicosis, asbestosis. Okay, similarly when the patients who are working in coal factory, okay, what is the disease? Coal workers pneumoconiosis, CWP. CWP, coal workers pneumoconiosis. Okay, CWP. So they are patients who are working in coal factory. Now I'm going to ask one important question to you people. You people answer it. A patient of coal worker pneumoconiosis, okay, he develops and he's a case of an rheumatoid arthritis. Okay, what is that syndrome called as? Rheumatoid arthritis with coal workers pneumoconiosis. What is that syndrome called as? Rheumatoid arthritis. Yes, very good, very good. So, two, three people have answered it very correctly. Kaplan syndrome, CAPLAN. I don't know for what reason these questions are very favorite for examiners. They're simply asking this. Even in UK exams, they have asked this. Okay, right. Now, next question, one more question. I'm asking you in CWP, okay, in rheumatoid arthritis, in lung, there will be one nodule formation. What is name of that nodule? A nodule formation in rheumatoid arthritis and CWP. Can you name that nodule? Fine, no problem. It's a tough question. Answer is necrobiotic nodule. Necrobiotic nodule. Necrobiotic nodule. Okay. So remember these terms: Kaplan syndrome, necrobiotic nodule. They are all rheumatoid nodule. Very good. Very good. Very good. Now all are answering. Good. Jayashree, very good. Okay. So this is called as necrobiotic nodule or rheumatoid nodule. Right. Now you're understanding name, age, sex, occupations. Okay. Then in pulmonology, we also ask about the water. What is the socioeconomic status? Okay, socioeconomic status of the person. Why we need to ask about socioeconomic status? Anybody, can you answer? If the patient is it is a low socioeconomic, what is the problem? If it's high socioeconomic, what is the problem? So straightforward, I'm asking the question to you. A patient belongs to low socioeconomic class. What are the diseases he is prone to? Very good. So many people started answering. Low socioeconomic class, that means they will be overcrowded, no proper ventilation. So as a result, these people are having high risk of developing infections, especially tuberculosis. Okay, tuberculosis is India is a hub capital of tuberculosis and also many infections. So definitely TB and infection. Very good, very good, very good. Right. Now my next question is changing. High socioeconomic class. What are the respiratory diseases? High socioeconomic class. Asthma, malignancy, asthma, no. Somebody, Granger Gal, okay, she answered correctly. OSA, okay, obstructive sleep apneas, okay. Why obstructive sleep apneas? Because OSA is a disease related to obesity. Do you think a person who is malnourished or in very low socioeconomic, he will be fat, or a person having a high socioeconomic class who is daily eating burgers and pizzas and sleeping in AC, he will be fat. Definitely obesity is more common in older, that high socioeconomic class. When obesity is more in high socioeconomic class, what lung diseases they can cause? Obesity and lung disease. Obesity and lung disease. What are the diseases? Number one, OSA, obstructive sleep apnea. You see, right? A big person will be sitting and sleeping like this, like that he will be doing. Okay, that is the classical case of obstructive sleep apnea, OSA. Similarly, one more disease is there related to obesity, that is called as OHS. OHS, that is obesity hypoventilation syndrome. Obesity hypoventilation syndrome. Can anybody name what is obesity hypoventilation syndrome also called as? Obesity hypoventilation syndrome is also called as, it is called what? And in which cartoon? Yes, very good. Shirley, very good. Yes, she answered it correctly. Shirley said it is Pickwickian syndrome. Pickwickian syndrome. Obesity hypoventilation is called as Pickwickian syndrome. Please, if you people don't know, no problem. Please make a note of it. Have a note ready. Keep writing the points. Very simple. Okay, Pickwickian syndrome. Right. And one more important, based on which cartoon they have, one cartoonist, one famous cartoonist, his name is Charles Dickens. Charles Dickens, you all would have known. Charles Dickens, in his cartoon, he kept a boy named Adam Joe. Okay, and Joe Adam was a guy who was suffering from this obesity hyperventilation. He used to be very fat and snore, and he used to bang in the walls, they say, because of carbon dioxide retention. So came the name as Pickwickian, right? Right, very good. Abhi, correct. Right, so Pickwickian syndrome. So you understood, right? So these are the diseases related to the obesity-related diseases, more seen in higher economic class. And in exam, please, when you are saying the class, please say it correctly, because they will ask you. Because in my senior exam, they asked this question. He said the patient belongs to low socioeconomic class. Then they asked, how are you saying? Then he did not answer. So please calculate the Parikh's classification or modified Kupusamy scale or BJ Prasad classification. These are the classifications there for showing what or for calculating the socioeconomic class. Parikh's classification or BJ Prasad classification or modified Kupusamy scale. Everything is available in our Parks textbook. So please make a note of the textbook of that modified of that socioeconomic class and calculate the socioeconomic class according to that and keep it. So as a result, you people in exam, if the examiner asks you why are you saying is low class, you can say according to the Parikh's classification or BJ Prasad's classification, patient is having a per capita income of only 700. So it is below, according to this, it's belonging to class 5. So it is low socioeconomic. So like that, you should answer in front of the examiner. For that, you have to know the things very properly. Okay, so you understood the introduction part. So if I see any case, name, age, sex, occupation, and socioeconomic class, I'm retaking. Similarly, we ask the residents, right, from where the patient is coming. Is it important? Okay, a patient is saying I'm coming from Chennai. One more patient is saying I am coming from a village. Okay, a village in Coimbatore area. Is there any difference between the both? That means my question is urban population, rural population. What are the diseases in urban population? What are the diseases in rural population? This is my question. You can answer. Come on, make it interesting. Air pollution is there, definitely, very good. So what is the problems because of air pollution? Yes, very good. So when you are in an urban population, it is highly polluted. So you have got chances of what? Rats, reactive airway diseases. Number one. We have got chances of what? COPD, chronic obstructive pulmonary disease, because of continuous thing exposure to pollutants. We have got chances of lung cancers, right? Lung cancers more in the urban industrial areas. Okay. Whereas if you go to the rural areas, there is chances of more of farming. Okay, they use farm, so more of pollens and climatic cools. So there are chances of what? Hypersensitivity pneumonitis. There are chances of allergic asthma. Okay, allergic disease related disease, asthma. Okay, and then hypersensitive pneumonitis, that in the form of farmer's lung. Okay, so these are the some of the diseases which are more common in the what to say, rural areas. Okay, so this also you must know. So these are all concepts should be in your mind. Okay, so that you just differentiate all these things, and these all are very important to clinch to a diagnosis. Okay, because when you're going to say a diagnosis, you have to say why are you going to say the diagnosis. For each and everywhere you have to pick a point. from introduction one point, from history these points, from examination these points. So I'm going to say this diagnosis that forms an correct scenario. Okay, right. Having finished this introduction, let us go next to the history taking. Okay, so I will be very fast with the history taking part. I'm not going to spend much time in history taking and examination. Okay, because already it is 7:10. Because but I'm going fast. But very importantly, you people have to go slowly only. Okay, if you ask me to talk about cough, I can talk 1 hour about cough. Minimum 1 hour it will take to finish cough, because such points are there to understand the clinical concepts of cough. But problem is we don't have that much time. Okay, our lectures are limited very fast, so we don't have that much time to discuss everything. So I will be just touching some nutshells, okay, about everything, and you can discuss it further or read it further. Okay. So now coming to the symptomatology. Okay, what are the cardinal symptoms of the respiratory system? Number one is very important, is cough. Okay. Number two is breathlessness. Number three is chest pain. Number four is will be having a what, wheezing, that is a noisy musical sound from the mouth. Then there's something called stridor, noisy breathing from the mouth. Then there is something called as a running nose, sore throat, sneezings. All these are related to the respiratory tract, right? Hoarseness of voice, blood in the sputum, that is hemoptysis. All these are cardinal respiratory symptoms, no doubt in that. Okay, now coming to the constitutional symptoms. Constitutional means these are the diseases which are having symptoms not only in respiratory but also to others. Example, fever. Okay, when you're having a fever, loss of weight, loss of appetite. Okay, so these are all the constitutional symptoms. They are not only pertaining to the respiratory system. Okay, right. Now in this very importantly, you have to ask all these symptoms to come to an idea. You understand it? Okay. Example, now first we will take about cough. Okay, so what are the, I'm going very fast. Okay, what are the things we ask in cough when a patient coughs? Okay, we used to ask many things, like what, for how many days, the duration of cough, whether it is acute, subacute, or chronic, whether it is a dry cough or productive cough. Suppose if it is a productive cough, we will be asking about the amount, color, consistency, smell, then is there any foul smelling discharge, everything we will be asking. Okay, suppose if it is a dry cough, here one examiner will ask a very important question: what are the causes of dry cough? Please make note of this question. All the answers are available. Available even in my book also. Okay, I will be showing my book, how to read my book, in the end of the session. Okay, you can go through and read it. You will cover entire pulmonology in that, no doubt. Okay, right. Clinical pulmonology. Okay, right. So similarly, after that we are asking about what, whether the cough is having any postural variation, whether the cough is having any diurnal variation, whether the cough is having any seasonal variation. Okay, so postural variation, diurnal variation, seasonal variation. So these are the different variations. So the cough, if you ask a cough, you have to say all this one. Example like this, patient, you have to present like this. So patient is having a cough for nearly 1 month. It is an productive cough. Okay, and which is white in color, mucoid in consistency, and it is not foul smelling, not mixed with any blood. Okay, and their cough is not having any postural variation, diurnal variation, or seasonal variation, and there is no any specific character of the cough. So like this, the point should come fatafat. Okay, it should be very fast. Okay, so the fluency of it, terino, that is the concept. Okay, right. So and there are special characters of cough. Example, just for an 2 minutes, just for entertaining you people, I will be doing some cough. Okay, and you people can identify what could be the cause for this cough. Okay, right. Now you itself say what is the diagnosis. Suppose a patient is coming and he's sitting there and he's coughing like this. What is the diagnosis? Apurva. What Apurva? Is it whooping cough? No. Okay. For Apurva, I'm answering now. How will be the whooping cough? See, whooping cough will be like this. This is whooping cough. Are you understanding? Whooping cough caused by Bartonella pertussis. Okay. It will be like this. Patient will whoop. This is called whooping cough. So it is called whooping cough. Okay. What I did. This is, don't you think it is like a lady dog barking? Okay, barking cough. Okay, this is called barking cough. It is seen in acute epiglottitis. Okay, it is seen in acute epiglottitis. Very good, Aditya. Okay, now let me show you another mimicry, and you people say what type of cough it is. Okay. Apurva, from which medical college you are? Can you please answer? Reply that, Apurva. Just out of consciousness, I'm asking. Okay, right. Second question. Second, I'm just doing another cough. Okay, see what is this? What is this? Harpaganaga. Right. Say. What is this cough which I did? CA lung, choking, croup, metallic, bovine. Very good. Bhatma Priya finally answered the correct answer. It is bovine cough. Have you not? Are you not able to feel like some buffalo is screaming, "Oh, mo," like that? Right? So that is a bovine cough. Okay. So bovine cough is seen in water. CA larynx. So many people have said correctly. Carcinoma of larynx. Okay. Bovine cough. Carcinoma of larynx. Okay. Metallic cough. Okay. It will also be looking similar like this bovine cough. It is seen in recurrent laryngeal lung paralysis. RLN paralysis. Recurrent laryngeal will be getting an bovine. So like many coughs are there. I will do one more mimicry. Try to find what type of cough is this. Yes, Apurva. You know, what is this cough? Anybody? Fine. What I was trying to do, this is an hacking cough. HACKING. Hacking cough. This hacking cough is seen in chronic smoker. Pharyngitis, like pharyngitis only to look. Okay. Hacking means the patient will hack. So when the patient is chronic smoker, because of irritation in the throat, he will not be able to speak much. He will try to say some sentences. Hi, Apurva. He'll be doing it. So that is called as a hacking type of cough. Okay, seen in smokers. Okay, one more cough mimicry I will do. Okay, with this we'll finish the cough. Okay, find which type of cough is this. What is this type of cough? Why I am doing? You have to note me carefully. Okay, say it. I think if it's a live web conference having 250 people there, it will be more interactive, right? You can see all the faces and do some comedies. Very good, very good. Granger again, sir. It is a suppressed cough. It is a suppressed cough. Very good. It is seen in pleuritis. Very good. You people are reading superly. Okay. Suppressed cough seen in pleuritis. Did you see the action? I am keeping my one hand here in the periphery of the lung. Why? This is the regions for the pleuritic chest pains. Okay. And I am holding the pleura so that I should not get that pain. Because why I am getting pain when I am coughing, these pleuras come in contact to each other and there will be severe pain. So as a result, I'm trying to suppress my own cough for the fear of this pain. This is called as suppressed cough. Okay, right. So these are the different characters of cough. The list is ongoing. Okay, there's nagging cough seen in tracheoesophageal fistula. Okay, hacking cough, whooping cough, a lot of characters of cough is there. Okay, so these if you that's what I said, like 1 hour it will require to cover about the many points in the cough. Okay, so okay, patafat we will go to the next topic. Okay, into the breathlessness. Okay, in breathlessness, what and all we will ask in the breathlessness. Number one, yes, very good, Aditya. Correct. Parietal pleura is involved. Parietal pleura is pain sensitive, right? Okay. Second, in breathlessness, will be onset, then there is duration, then progression. Okay, so 6 months the patient is having breathlessness. Then how is the onset? Insidious in onset or sudden onset? Then how is the progression? Okay, whether it is gradually progressive or non-progressive. Okay, then we have to grade the breathlessness, grading of breathlessness. Then there is something called as whether the breathlessness is having associated with any orthopnea or PND. Okay, so these are the points in which we have to discuss the breathlessness. In this, the common questions asked by the examiner is, what are the causes of acute onset of breathlessness? Causes of acute onset of breathlessness, very favorite question for the examiner. Many causes are there, like tension pneumothorax, acute exacerbation of asthma, acute exacerbation of COPD, cardiac tamponade. Then there is an acute foreign body obstruction, anaphylaxis. Then there is an hysteria. Okay, so like that, many causes are there. We can keep on saying. Okay, yes, I be correct. Pneumothorax, right? So these are the acute onset of breathlessness. This is a very favorite question for the examiner, no doubt in that. Okay. The next question they will be asking about the grading of breathlessness. In grading, please make thorough with the grading. There are two types of grading. One is pulmonary embolism will cause breathlessness acute onset, but why did I not say means pulmonary embolism breathlessness depends upon the grade of embolus. If it is a massive embolism, definitely there will be acute onset of breathlessness. But if there's a small embolus, then breathlessness maybe of not severe intensity, right? Okay, grading of breathlessness, examiner will definitely ask, please make important note of the gradings. Please divide the gradings into divide the gradings into cardiovascular and respiratory. Cardiovascular grading, we have got one important grading in cardiovascular serious disease that is called very good, NIHA classification, NIHA, New York Heart Association, NIHA classification. In another side, we have got a respiratory classification. In respiratory, we have got a MMRC. Okay, in respiratory, we have got MMRC. What is MMRC? Modified Medical Research Council. Modified Medical Research Council. MMRC grading of breathlessness. Then we have got something called as Sherwood-Jones classification of a breathlessness. MMRC and Sherwood-Jones. Okay. So these are the types of the breathlessness. Many things that are there to discuss. Then they will ask what is orthopnea. Okay, how much time will it take for orthopnea to develop? Okay, they will ask what is platypnea, what is trypopnea, what is eupnea, what is apnea, what is hypopnea, what is hyperpnea. Okay, all these questions can come in that. Everything is available in the book. Okay, if you start discussing one by one means you have to discuss like that only. But since the sessions are very small, I'm just throwing some sands so that your mind should get, oh, a lot of things are there to read, and I should be very important. Okay, so in breathlessness, please be thorough with these areas. Please be thorough with grading. Please be thorough with all these orthopneas and trypopneas and platypneas and PND. What is an attack of PND? 100% in MBBS they'll ask all these questions. Okay, next we'll go fatapat to the chest pain. Chest pain in pulmonology, especially in pleuritic type of chest pain. How will be any chest pain? How will you say? We will say what is the site, how was the onset, what is the character of pain, whether it is radiating or not. Then we will say whether it is associated with any other factors. Example, a pleuritic pain, aggravating and relieving factors also we have to say. Okay, example, a pleuritic pain, how will I discuss? I'll be discussing in these points, right? I'm having a pain for nearly 1 hour or 2 hours, okay, which is present in the right-sided pain in the peripheral region. Pain may be either central or peripheral. Pleuritic pain is peripheral, correct? So a peripheral type of pain, and this pain, how it is going to be? A pricking type. Please note it, pricking type, like a sharp injection, how you prick. Okay, so lancinating or a pricking type of pain, or sometimes we can also call it as a stabbing, like katti kutra mari irukum. Okay, stripping or a snapping type of pain, and which is aggravated by deep inspiration, or coughing. Because why the pain? So this is the parietal pleura and this is the visceral pleura. When you do a deep inspiration, they both come in contact. That time the pain will come, because the parietal pleura is pain sensitive, right? Okay, so deep inspiration, the pain will come, and when you're coughing, it will touch the pleura, pain will come. Are you understanding? So it is aggravated by deep inspiration or coughing, relieved by. I asked a question to one of my students. Okay, man, these are the aggravating factors of pleuritic pain. I asked a question. What did I ask is, what are the relieving factors for a pleuritic pain? He said, sir, by deep inspiration it is happening. Okay, don't breathe. This was his answer. If don't breathe, what the patient will happen? He will die or not. Okay, so please think logically before you answer. Okay, directly don't say don't breathe. Then another, then if you're asking again, he's saying, okay, don't cough. How can we not cough? Suppressed type of cough. Okay, so don't cough, don't breathe. Please don't answer like this, sir. Answer is lie on the same side. Okay, lie on the same side. Why? Because when you're lying on the same side, this part is being given a rest with the floor. So as a result, the opposite lung only will move, and it will take over the function of the affected lung, right? So these are the questions in the chest pain they can ask you. I'm going a little bit fast. Next, some important points are there. Example, don't use the terms like dyspnea, wheeze, hemoptysis. Don't use like these terms. Always use the patient's own terms. Example, for wheezing, if the patient is saying I'm having wheezing, no patient will directly come and say he's having wheezing. There are some educated patients, if they say, you can write. Otherwise, most of the patients will say மூச்சு விடும் போது விசில் அடிக்கிற மாதிரி சத்தம் கேக்குது. ओके जब मैं सांस ले रहा हूं तब सीटी बजने के आवाज जैसा लग रहे हैं அப்படின்னும் ஓகேங்களா so patient will be you have to write like this so patient is having an whistling like sound in the mouth ஓகேங்களா so that should be your symptom then patient is having noisy breathing when he is breathing noisy breathing means what it is stridor so wheeze stridor wheeze is because of bronchoconstriction whistle like sound stridor is because of upper airway obstruction and noisy sound right similarly instead of using the word hemoptysis please use the word blood in sputum okay blood in sputum that will be more effective okay so you have to use the term patient is complaining of the blood in sputum that means it is hemoptysis okay ma right so these are all some of the important terms in hemoptysis also if the many questions are there everything we can refer in the book okay now fatafat after the important history the end of the history negative history is very important negative history means what means it is our duty to rule out cardiology causes right because even the chest pain breathlessness cough is seen in cardiovascular diseases also correct respiratory cardiovascular both are having same complaints like breathlessness chest pain and cough so it is important duty to rule out cardiovascular diseases so what are the symptoms we have to ask for ruling out cardiovascular diseases apart from these things please ask about palpitation so make sure there is no history of palpitation there is no history of any syncopal attacks there is some transient loss of consciousness there is no history of swelling of legs indicating what heart failure no history of any reduced urine output indicating of heart failure okay so when you are saying these points no palpitation no syncope no swelling of legs no decreased urine output so these points will make the examiner give an impression that this guy is ruling out all the cardiovascular causes are you understanding okay so these are the importance in history taking so a history it should be complete and it should rule out all the possible other causes okay that is the important சம்பந்தமே இல்லாம without any link patient will come with cough our person will be saying patient has no history of diarrhea like that so if you're saying no history of diarrhea in a patient of cough what is the link between diarrhea and cough you should be able to say why did you ask that if they ask me I will give an answer yes I can link example if you are having a legionella pneumonia it is a type of atypical pneumonia legionella pneumonia affects the abdomen also it causes diarrhea in those patients okay so since the patient is having fever this thing I'm suspecting this okay right now coming to the constitutional symptoms what are the constitutional symptoms I said fever okay fever especially it depends it's seen in infection especially bacterial pneumonia I'm having a little bit of the fan allergy okay especially of the bacterial pneumonia how will be the fever it will be a high grade fever with chills and rigor high grade fever with chills and rigor whereas if you take an TB there is a low grade fever with an evening rise of temperature okay low grade fever with the evening rise of temperature okay so they will ask another question why there is evening rise of temperature in TB yes you people answer long time happen you people answer why there is evening rise of temperature in tuberculosis evening rise of temperature in TB yes very good cortisol effects okay so as exactly in the early in the morning TB generally the pathogen it is not highly pyrogenic so there will not be a great temperature so in the early in the morning times what will happen is that generally there will be more steroid production cortisol production in our body and as the day goes on the level of steroid production will come down so in the morning times the cortisol will mask the effect of the fever and in the evening time the fever comes out so they say it as an evening rise of temperature very good okay right next after this history now we are going to go to the past history we importantly ask about the tuberculosis history asthma history COPD history apart from them as a routine diabetic hypertension then ischemic heart disease epileptic everything I'll just fatafat say the links between all diabetic they are immunocompromised so diabetic patients are more common of developing TB pneumonias okay please take it to mind so before the TB was a disease of the water low class people okay but now the TB this is also high class people because high class people are having diabetes more commonly and because of the TB super infection is happening okay similarly if you take other diseases like epilepsy patient they have got chances of aspiration so aspiration pneumonia okay chances are there in epilepsy Clear. Similarly, if you take asthma, what is the importance? Means if the patient is already a known case of asthma, it will be allergy. He could be an asthma or allergic rhinitis. We can come to an area. Similarly, past history of TB is there. Then definitely you will be having post TB complications like fibrosis, collapse, calcifications, hemoptysis, scar carcinoma. These are all complications because of TB, bronchiectasis. Okay, so all these things should go in your mind. So when you are explaining the past history of TB, this area many students are doing mistake. When you are explaining the past history of TB to your examiner, please don't just say that patient has got TB 10 years back. That is not the answer. You have to explain each and every point. Okay, when he was diagnosed as TB, what type of TB, what sample was done, where it was done, whether he was registered under DOTS. Okay, RNTCP. Now it is changed to NTEP. Okay, NTEP. Whether the patient took the entire 6 months of course, after the entire 6 months of course, whether he was declared as cured. All these points must be asked. Okay. Example: when I am presenting, I should present like this. Sir, my patient developed tuberculosis 10 years back. It was a pulmonary tuberculosis, which was diagnosed by a sputum microscopy, and patient was found positive in that sputum, and he was started in DOTS. He was registered in the government. Patient took nearly 6 months of entire course of treatment, and the total course was uneventful. He did not skip any courses. At the end of 6 months, the patient again sputum was done, and it was negative, and the patient was declared as cured. If you give a history like this, the examiner will be very happy. Wow. Okay. If you're just saying patient got TB 10 years back, what should I understand? What TB? Because TB affects everything starting from head to foot. TB does not cause pregnancy. Other than that, TB causes everything. Okay. So you people must be very nice, good dictator in impressive way to say the questions and to say to present your case. Okay, so past history of TB, I said many complications are there because of TB. Next we'll go to the personal history part. Okay, personal history. What we ask about is diet, we ask about his sleep, bowel habits, bladder habits, but very important to the pulmonology concept, whether he is a smoker. Okay, why? Because in our long case, COPD will be kept as a long case, lung cancers will be kept as a long case. So we people should know about the smoking in and out. Today in Hello app, I have gone for a live for nearly 1 hour explaining to the public. Nearly 10,000 people have 12,000 people have joined, and I explained to all of them about all the points about smoking. Okay, so Madhumita, please tell about smoking index. Yeah, definitely I will say about smoking index. In smoking, what and all questions they can ask you is they'll ask this bunch of 10 questions. Everything is there in my book. Everything is there in my book. RS by RS. Everything is there in this 200 pages. No doubt in that. But anyway, I'm going to say you patapata. If you are missing any points, please refer my book. In 3 days, you can complete my book and you can master all this. This book is only for practicals. Only for practicals. I will explain you in last how to read this book. Okay. Fine. In smokers, first what of all you have to say what he is smoking. Example: bedia, cigaretta, pipa, cigara. These are different forms of this. Second thing, what he is smoking, how long he is smoking. Okay. What is the importance of knowing how long he is smoking? By knowing how long he is smoking, we people are going to calculate two things. Number one is pack years. Number two is smoking index. Pack years and smoking index. Madhu, this is the answer for you. Nikhil also, this is the answer. What is pack years and what is smoking index? Pack years means what? Means number of packets of cigarettes smoked per day into number of years. Number of packets of cigarettes smoked per day into number of years. Are you understanding? Example: a person has smokes daily one packet of cigarette. Okay, example ask. One packet of cigarette means how many cigarettes? One packet means 20 cigarettes. Okay, one packet means 20 cigarettes. That is the international standard. According to Indian standard, one packet means 10 cigarettes. Okay, but international standard means it is 20 cigarettes. So we have to say your answers according to the international standard. So one packet means 20 cigarettes. So I'm smoking one packet per day for nearly 20 years. My pack years will be 1 into 20 is equal to 20. Understood? Suppose the person is saying, sir, I'm smoking that small packet, then put half. Half into 20 is equal to 10. Simple. Okay. Then there is something else called as smoking index. What is smoking index means? Number of cigarettes smoked per day into number of years. Number of cigarettes smoked per day into number of years. Example: a patient is saying, I'm smoking 10 cigarettes per day for 10 years. So smoking index for 10 into 10 is equal to 100. Clear? What is the importance? Example will ask, what is the importance? Answer is, if the pack years is more than 30, if the smoking index is more than 300, patient has got high chances of developing cancer. Simple. Okay. If the PAT case is more than 20, smoking index is more than 200, patient has got high chances of developing what? COPD. Okay. So this should be your answer, okay, for your those questions. Okay, then there are many questions in smoking, like who is a smoker, who is called as a smoker, what is an active smoker, what is a former smoker, what is an ex-smoker. Okay, what are the effects of nicotine in the body, what is active smoking, what is passive smoking, what is first hand smoke, what is second hand smoke, what is third hand smoke, what is mainstream smoke and what is side stream smoke. Everything is dealt, everything is dealt. Okay, so don't worry, we will just know these questions are all there, you can ask you in the exam. Okay, then after that personal history, then there's something called family history. Any familial diseases, especially like asthma, they are all familial diseases, please make a note in that. Then fatafat will, because already time 1 hour is over. Okay, we will go to the examination part, then I will talk just about the cases in upcoming, then the scope of pulmonary medicine, and there we end the session. Okay, examination, I think we have to have an separate sessions, lively demonstrating in front of the patient. That will be better. Okay, in my book I have dealt with all the pictures, but always when you people present a case, you can arrange an inter-college. You people, all the medical colleges people, can arrange an inter-college conference like a CME, like that, and where you can call different experts, and you people, like you people can divide into batches, and you can present a case. Okay, example, some thousand students are coming for a conference where CVS case, RS case, CNS case, everything is there. There you can put me as one of the faculty for respiratory, and students of a batch, you can discuss 100 batch per students, and you can keep it in auditorium where 100 people can sit, like the 5-6 auditoriums, and you can present the case lively, and where 100 students, we can lively demonstrate in front of them. That will be very useful, I think. Okay, and it will be very grasping also. So try to arrange something like that for discussing the examination parts and all, because even this also I am only speaking, I don't know how many people are lively taking the points in into your mind. Okay, so examination of respiratory system, first of all there is a general examination. In general examination there is consciousness, orientation, then we are having our built nourishment, then we are having our pickle, our pallor, icterus, cyanosis, clubbing, pedal edema, lymphadenopathy. Then we are going to the vitals. Vitals, TPR, BP, temperature, pulse, respiratory blood pressure, SpO2. SpO2 is an important component in respiratory cases. Then we are going to the examination of respiratory system. Each one has got their own points. Example, consciousness, the examiner can ask you, what is the link between consciousness and pulmonology? So altered consciousness, what are the respiratory causes of altered consciousness? So your answer should be like respiratory, type 2 respiratory failure, type 1 respiratory failure, like that. Pallor. Okay, many questions are there. What are the respiratory causes of pallor? What are the respiratory causes of icterus? What are the respiratory causes of cyanosis? What are the respiratory causes of clubbing? What are the respiratory causes of lymphadenopathy? What are the respiratory causes? So everything is there in the book. Okay, and everything, each questions what I'm asking now can be importantly asked in your exams. Just understand how much you have to read. I'm just talking about the lungs only, and in that how much is there, that means how much ever you have to cover it. Okay, that is the concept. Okay, then vital, similarly, pulse, what are the pulses linked to the respiratory system? Example, there is a, okay, I think you people can take this answer. Pulse and respiratory system, what are the pulse related to the respiratory system? Answer. Pulse related to respiratory system. Water hammer pulse. Then no. Okay, I will answer. Okay, so pulse and respiratory system. Very good, very good, very good, very good. Pulses paradoxes. Abhi Abraham, very good. So pulses paradoxes is seen in severe attack of an asthma, severe attack of an COPD, tension pneumothorax, cardiac tamponade. So pulses paradoxes is also called as pulses normalis aggregans. Okay, normalis aggregans. It means there, during inspiration there will be fall in the blood pressure, more than 10 mm of Hg in upper limb, more than 20 mm of Hg in the lower limb. So that is pulses paradoxes. Similarly, many pulse will be having a low volume pulse in respiratory failure and severe tension pneumothorax. We may have low volume pulse. High bounding pulses will be having in carbon dioxide narcosis, that is type 2 respiratory failure, will be having a bounding pulse, that like the bounding pulses. Okay, so these are some of the different type. Example, irregularly irregular. We know it's coming in atrial fibrillation. Atrial fibrillation is one of the very important complication of obstructive sleep apnea. Very important arrhythmia seen in COPD. Okay, very common arrhythmia seen in COPD. One question I'm asking you: most common arrhythmia seen in COPD. Answer. Most common arrhythmia seen in COPD. What is the most common arrhythmia seen in COPD? Anybody? Come on, be fast. Abhi Abraham, I think you can answer. Yes, very good. Very good. Okay. Answer is MAT. M-A-T. Please make a note. MAT. Multifocal atrial tachycardia. Multifocal atrial tachycardia. It is the most common arrhythmia seen in COPD. But atrial fibrillation is also associated with the COPD. Just have a note of it. Okay. So like this. So like this. So like that. Pulse and respiratory, BP and respiratory, saturation and respiratory, temperature and respiratory. The questions can be asked at any point over here. Okay. Right. Then they can go into the examination. Examination of respiratory system has got examination of upper respiratory tract and examination of lower respiratory tract. Upper respiratory tract, we have to examine the ear, nose, and throat. Many points are there. Please, we can refer the books. Say, example, nose, you are having black crust. It can be because of a granulomatous vaginous granulomatosis. Okay, DNS, there's a chance of an allergy. Polyps is a chance of an allergy. Like many points are there. Okay. And when you're coming to the lower examination, there is something called as inspection, palpation, percussion, auscultation. As I said, we need separate live sessions for this. In medical colleges, we can conduct. It will be very useful for you. Just by simply speaking out this live session, it will not. I will not able to teach you the examination part, because examination part is a live part where you have to witness the patient in front of the eyes, so that will go into your mind. Okay. So in inspection, many points are there. In palpation, many points are there. Any doubts you are there, we can discuss in subsequent cases in that. Okay. According to that. Otherwise, if we go inside that, it will be boring without having the patient. Okay. Then finally, after the end of inspection, palpation, percussion, auscultation, we come to something called as what, other systems. In other systems, we have got cardiovascular system, we have got abdominal system, and CNS. We just check whether all these systems are normal, and finally you are going to come to an diagnosis or a differential diagnosis. Your diagnosis should have all the three components. Okay. All the three components means what? Anatomical component, pathological component, etiological component. Anatomy means what? What are the anatomy in our respiratory system? Upper respiratory tract. My question now to you all people, answer, very important question. What is the landmark to differentiate between upper respiratory tract and lower respiratory tract? Landmark to differentiate between upper respiratory tract and lower respiratory tract. Answer. Where is Apurva? I think Apurva is left. Not at all active. Answer. Very good, very good. Okay. So Roshni, Sendil, everybody have answered correctly. Answer is lower border of cricoid cartilage. Lower border of cricoid cartilage. Anatomically, that is the landmark. If you go inside and see, there is vocal cords. Correct. Okay. So vocal cords above, it is upper respiratory tract. Lower to the vocal cord, it is lower respiratory. Apurva, you are there but not answering. So only I'm asking you. Okay. Then below that, it is the lower respiratory tract. Okay. In the lower respiratory tract, okay, I think I should have brought some paper and pen so that I could have drawn and shown you. Let me check. Okay, right. I think people can see it, right? Right. See, if you see, so I put a line like this. Okay, so this is the trachea and this is the bronchus, right? So trachea and the bronchus. So this is the trachea and the bronchus. This region is the conduction region where the air comes and goes like this. Okay, so this is called as airway. This is called as what? Airway. 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 So these diseases are called as airway diseases. So what are the airway diseases? Example: bronchial asthma, COPD, chronic obstructive pulmonary disease, okay, bronchiectasis. All these are airway diseases. So this is the pathological. This is the anatomical airway diseases. This is an anatomy. Okay. Similarly, okay, so I had drawn a lung over here. See, so any problem in this lung parenchyma, any problem in this lung parenchyma, this is called as what? Parenchymal diseases. Parenchymal diseases. Parenchymal diseases are many. Example, it could be infection, it could be malignancy, it could be cavity, consolidation. All things happens in the lung parenchyma. So it is parenchymal involvement. Then see, now I have drawn a covering. Okay, so can you see this covering? This covering is called as pleura. This covering is called as pleura. So this disease is called as pleural based diseases. Pleural based diseases. So what are the pleural based diseases? Pleural effusion, pneumothorax, okay, pleuritis. Okay, all these are pleural diseases. Right? Right. So airway diseases, parenchymal diseases, pleural diseases. Then in between these both the lungs, in between both the lungs, there's an area over here. This is called as mediastinal. Mediastinal. So there is something called mediastinal diseases like like mediastinal masses, lymphoma, thymoma, cyst, everything would have it. Okay. Then similarly, now focus this. Below this, I have drawn one circle like this. This is the diaphragm. So there is something called as diaphragmatic lung diseases. This is because of the diaphragmatic palsies, okay, diaphragmatic injuries, diaphragmatic lung diseases. So overall, when you're saying an anatomical diagnosis means you have to come to an idea at the end of examination whether your problem is in the upper respiratory tract or lower respiratory tract. If it is in lower respiratory tract, whether it is airway, parenchyma, pleura, mediastinum, diaphragm, what it is. This is the knowledge which you have to develop. For this purpose only, behind your name you are having MBBS. Okay, if you are not able to do this, no need to put MBBS. Directly the pharmacy people will itself give cough syrup instead of you. Are you understanding? Because you itself think if a problem is there in the airway, okay, example asthma, that time do you think antibiotics will work? Do you think pleural tapping will work? No. What will work? Bronchodilator, salbutamol will work. Are you understanding? Inhalers will work. Suppose a patient is having a parenchymal lung disease, per se is having an infection. That time, if you give inhaler, will it work? No. That time, antibiotics only will work. Are you understanding? Example, if a patient is having a pleural effusion or a pneumothorax, that case you are giving an inhaler, you are giving an antibiotic. Will it work? It will not work. What will work? Only pleural tapping or an ICD insertion for pneumothorax only will work. Are you understanding? This is the concept which I want to break through to each and every one of you. Are you understanding? This concept should go inside all your minds. So the duty of the doctor is to find where is the anatomical problem. How sir I will find the user very fatapat. You can find example, if I'm having a patient with a cough with expectoration means there is a sputum formation. Sputum formation means the sputum will never come from pleura, sputum will never come from diaphragm, sputum will never come from mediastinum. That means the sputum will come only from the parenchyma. Sputum may come in a little amount from airway. So if a patient is having a sputum protection, either it should be airway disease or a parenchymal disease. And in that also, the sputum is coming in more amount, in copious amount. That means definitely it should be in parenchyma. Are you understanding? It cannot be in the airway. Okay, because airway diseases like asthma will produce only mild sputum, but parenchymal diseases will produce more sputum. So if you itself think, if in the exam you are saying the patient is having a sputum production, massive sputum is produced, and the examiner is asking you what could be the cause, and you are saying the answer as pleural effusion, do you think it is logical? Do you think the answer, the examiner like me will be happy? I am a very young guy. Okay, I am only 27, 28 years. But 70, 55 years, 60 years old examiner, will he be happy hearing your answer? Definitely not. Okay, so you have to say some parenchymal diseases where more sputum is produced. Example, bronchitis, lung abscess, okay, and there is some infections, okay, like pneumonias. So there and all more sputum will be produced. Okay, so this is how you have to differentiate. Similarly, you are auscultating the patient. You are having bilateral wheeze. This wheezing sound you are able to hear. Now, if you are hearing a wheezing and you are saying the answer is pleural effusion, is it correct? No. Wheezing means is the problem of airway. That means his airway is gone for an bronchoconstriction. Correct? That means the problem is in the airway. So bronchoconstriction is there. It means the problem is there in the airway. So as a result, you are able to hear an wheeze Suppose you are able to hear a creps, creps. That means where is the problem? Do you think the problem is in the airway, or do you think the problem is in the pleura? No. If you are able to hear a creps, the problem is in the parenchyma. So it should be in parenchymal lung disease. So think of all the parenchymal lung disease. Okay. Suppose patient is having a Krebs, okay, and you are having all the parenchymal lung disease. Infection is there, cavity is there, consolidation is there, malignancy is there. How can I differentiate, sir? Everything are parenchymal lung disease. How can I differentiate? Like that, you can say, na. Okay, somebody has asked, sir, parenchyma doesn't have goblet cells. Okay, see, secretion, not goblet cells, because of infection. Okay, there will be what? There will be what? Necrosis. There will be necrosis of the tissues. That is how sloughing off is happening, and it is mixed and come. What is coming out is all pus cells, man. Okay, right. I'm just coming into the concept again. I'm just coming to the concept again. Okay, so all are parenchymal lung diseases. Example, if let you take infection or malignancies or an cavity or a fibrosis, all are parenchymal lung diseases. Okay, all are parenchymal lung disease. So the duty is how will it differentiate? By a proper history, you can differentiate. How? Example, I'm giving 2-3 scenarios. You people will understand. Example, a patient is there. He's a chronic smoker. He's having a big clubbing, and he's having an hoarseness of voice, nicotine staining in hands, and he's having an consolidation like findings. Bronchial breathing is there. Okay, what will you suspect? What parenchymal disease you are going to find in this bronchial breathing? Definitely, it should be a lung malignancy. Correct? Lung malignancy, because the history is like that. Old age, I have taken from the introduction. Okay, hemoptysis from the history, loss of weight, loss of appetite from the history. Correct? Cigarette smoker. So this comes to the diagnosis. Another scenario, I'm having a patient, 70 years old. He is again having a chronic chronic smoker. He's a chronic smoker. He's having breathlessness as his main complaints, and cough with expectoration also. And he's a chronic smoker. And bilaterally, he's having a barrel-like shaped chest. On auscultating, you're having a wheezing. What will you suspect in this case? Do you think this case is going to be a case of an asthma? Since he's having wheezing, no, it should be a COPD. Correct. Apurva came to form. Okay, so COPD. So definitely it is the correct answer, right? So like this only I'm saying. Okay, similarly, there's another guy, some 45-50 years old. He's working in Rajasthan in a tiles factory. He's been exposed to a lot of time in silica for more than 30 years, and he's having cough with breathlessness. And on a auscultation, there is scripts. In this patient, will you sit and think he's having asthma, or will you think of silicosis, a parenchymal lung disease? I will be thinking of silicosis. Correct? So this is what I'm saying. Okay, this is what I'm saying. A scenario is very important for a diagnosis. A scenario is very important for a diagnosis. So how to develop that scenario means taking the cases again and again, understanding the concepts of the pulmonology, and then executing it. You will not miss even one disease. Okay, so our main aim is to differentiate whether it is an airway disease, or a parenchymal disease, or a pleural disease, or a diaphragmatic disease, or a mediastinal disease, or upper respiratory tract. That is our main aim. So I have given some clues how you will approach what organ is involved, and you have to maintain, you have to put your diagnosis as anatomical, parenchymal, etiological. I'm saying a diagnosis of a case. See, like this. Okay, patient is having right upper lobe or right-sided fibrosis. Okay, right-sided fibrosis. So anatomically it is right-sided, and it is pathologically it is a fibrosis. Correct? Next, what I'm saying, fibrosis means it's a problem of the parenchyma fibrosis. That is pathological fibrosis. Then what I'm going to say, etiology, mostly secondary to tuberculosis etiology, which happened 10 years back. Are you understanding how simple it is? Right-sided fibrosis, okay, mostly secondary to tuberculosis, which happened 5 years back or 10 years back. Clear? So this is what how a diagnosis should be formed, and then we have to go to relevant investigations to confirm it. As I said, no need to do all the investigations. Only relevant investigations are important to confirm it. Are you understanding? Right. So I think in this 1 hour 20 minutes, I tried to just give an introduction, just a small introduction in the field of pulmonology. Okay, you also can give your feedback sessions, whether it is useful to you, whether it was useful to you, how my lecture was, whether you liked it or not. Okay, now I'm going to talk about the scope of pulmonology and how and what are we going to do in the subsequent sessions. Subsequent sessions, they had put a schedule in such a way that to discuss one case one day. Example, I think 5 6 major cases are there: pleural effusion, consolidation, carcinoma of lung. Okay, then we are having cavity, we are having fibrosis, fibrocavitary disease. So these are our main cases in the pulmonology. Okay, so we will be discussing about one cases, okay, per week. Then next, what we are going to discuss, maybe if some investigation, some important, they are giving some time, we can discuss, because you people have to learn not only pulmonology, okay, about all. Okay, but me being a pulmonologist, what is my advice to you people is that it is a very lovely branch. I love pulmonology like anything. If you ask me to talk about lungs, I will be talking day and night about lungs. I said, nah, I'm not going to keep my loved ones in the heart. My loved ones are kept in the lungs, because lungs, lungs. Every time I think about this organ, okay, what is happening in there, how it is happening, how beautifully it is designed, because I'm addicted to it. Are you understanding? I love that organ very much. I read everything. That is the reason when I was reading my MD second year itself, I started writing my book. Okay, I started writing my book, Respiratory System, a review of complete practical examination, RS by RS. RS means respiratory system. My name is also RS, Ravichandra Sabrinath. I think there's a link between already RS and myself. Okay, so I wrote this book when I was in my MD second year itself. I started writing this book. What is the main motto I started writing this book is that I was very much concerned that the art of clinical medicine should not die. The art of clinical medicine should not die. See, now I'm saying, without, I challenge anybody, without any CT scan or without any X-ray, I can say an exact correct diagnosis anatomically, etiologically, pathologically to any respiratory case. This is my open challenge to all. Okay, you bring any case. If I'm not able to diagnose, I'm ready to quit. Okay, that is my open challenge. How I'm able to boldly challenge, because that is the love I have towards my subject, dedication I have towards my subject. Okay, so because that much love I have to the subject, I really have to say I'm in tears really when I talk about my subject, because my subject is best subject. I love it. Okay, many people discourage me when I join, saying that hey, tibla aa gaya. What is the meaning? Means he's a TB doctor. What TB doctor? I'm not only a TB doctor, I'm a lung doctor, I'm a pulmonologist. Okay, TB is an one important disease which is present in India. As a result, it is affecting the lungs. I am treating TB. That's it. I'm not only a TB doctor, I'm a lung doctor. Even though I'm a TB doctor, what's wrong? TB is the main infection. We are all talking about corona left and right. Daily, 15 to 20 times more people are dying because of TB in India than because of corona. But are we debating about that? We are not debating about that. Are you understanding? Corona is a simple disease having a case fatality rate of 2.5%. In Tamil Nadu, it is only 0.5%. But whereas TB, how many people are dying because of TB, man? Very proud to say, man, that I am a TB doctor. No doubt in that. Okay, so love in the subject is very important, whatever subject you take. So what is I wrote this book. Okay, how I designed this book means clinical knowledge should go. Okay, now I'm writing another book. I'm writing a book for DM pulmonology entrance. It will be having 1000 MCQs for DM pulmonology. Speed Institute has asked me to write. I'm writing a book for that. Okay, I'm in the process of that. Okay, I'm doing that, no doubt in that. But this was my first book. My main aim was that not to do any income generation in this book. Main aim was to spread the knowledge of pulmonology. Okay, income God has given me a lot. Okay, I'm not towards it. Okay, so in this, if you see what and all the headings, see introduction to respiratory system, examination of respiratory system, viva questions. All the examination cases will be there in this viva session. All the exam cases, I said na, pleural effusion, consolidation, COPD, bronchiectasis, cavity, all questions with answers are there. I went to each and every professors, hearing what they say, and got all my questions. Okay, I have met professors of Jaipur Medical College. I have met professors of Mumbai GS Seth Medical College, the Ahmedabad BJ Medical College, Madras Medical College. All the professors, actually international, I used to go and just sit and watch what they are talking about, and my concepts and my questions were taken from all those points, and my own answer, my own question. So I had almost dealt very important questions as a UG. If you read this, respiratory will be a cake walk. guarantee. Cakewalk. Okay, cakewalk. Right. Then I have very importantly, I have added a chapter called spotters. Okay, spotters means example. I will show you one. Okay, example, see, there's a picture of a guy. Okay, and I will be asking question. Okay, what is this? What is the cause? Example, that was a case of an SVC syndrome. So my question will be like this. So then second, see, there's a picture like this. So what is this? Clubbing. So all the questions in clubbing will be there. Nearly 35 questions, 40 questions are there in clubbing. Everything will be there. Okay, so like this. So like this, lot of picture based spotters are there. How that spotter is linked to respiratory system. Okay, then there is also next chapter is about the OSCE charts. Okay, and there is also something called as X-rays. X-rays, I have added all the important chest X-rays, along with the explanatory answers. You people can just go through all these important chest X-rays, which will be kept in your exams. For postgraduate, thinking postgraduates in mind, I have also added my CT scan. I also added many CT scans, important CT scans that will be kept in the exam. Then there is also drugs to be kept. So these are the drugs, respiratory drugs kept in the exam. All the cough syrups, Nicotex gums, inhalers. So these are the inhalers. What questions they will ask in inhalers? Okay, about the entire PFR, nebulizations, bronchoscopy, thoracoscopy. So the list goes on. So what I want to say is this book was my great passion. It was my effort. It was my dream. I wanted to bring the concepts of clinical pulmonology to my students. So that is the reason why I put this book. Okay. So the scope in pulmonology is very great. I'm very young. Okay. As I say, I'm nearly 28, 29 in Chennai. But since two things are very important about the scope. Number one, you may be any field, you must be very dedicated to that field. You must be best in that field. You must be best in the field. That is very important, number one. Second very important thing is that you must be very good in speaking. What the patient requires is, patient does not, one person has asked, where can we get our book from? It is available at Flipkart. You can write Ravichandra Sabrinath. The publishers is Paras Publishers. Okay, parasredcard.com. It is also available at parasredcard.com. They do a home delivery. Even there is something called as what to say, Flipkart. Everywhere this book is available. Okay, even in stores also I think it has came. Okay, right. So you can take this book from there. You can give your feedback, and anything, if you have got any problem, we can update also. Okay, so coming back, what I want to say regarding the scope of pulmonology is that any field, two important things. Number one is your dedication and love. You should be having the best knowledge in the subject. Nobody should be able to pinpoint and make fool of you. Okay, you should be ultimate in that subject. That much you have to love your subject. That is the first point. Second very important point, what I want to say is that after you are loving to the subject, second important thing is that the way of communication. Patient requires a proper communication. Okay, patient requires a proper communication. Rate not very costly, man. It is something 250 rupees or 300 rupees. It is not 3000 rupees book. Since I am the first time new author is writing a book, it will be very cheap only. Okay, so it's 250 rupees only. It's very easily, it can be bought by you all. Okay, right. Second very important, what the patient needs is how we talk to the patient. Okay, example, when a patient comes, I will be throwing honey to them. You know what is honey? Such meeta baate. Yes sir, please come. Oh, you're having cough for how many days? Okay, is it so அப்படிங்களா? ஓ, ஒன்றும் பிரச்சனை இல்லை, சரியானில்லை, பார்த்துக்கலாம், ஒன்றும் பிரச்சனை இல்லை, எத்தனை நாளா இருக்கு? ஸோ அவர் சிகரெட் பிடிப்பீங்களா? டோன்ட் ஷோ யர் ஃபேஸ். ஓ, சிகரெட் பிடிக்கிறியா? அதனால எத்தனை பிடிப்பேன்? ஒரு ஆளுக்கு 10, 2 பேக்கெட்டா? Don't show like that arrogance. He is your patient. He needs some proper care. Please throw your care to the patient. Talk them very nice. Then even though your treatment is wrong, patient is yours. Are you understanding? Even though he's not having that much comfortable with your medicines, he will like your face, he will like your words, and he will be your patient. But think, if both join hands together, you're having a very good knowledge, and same time you're having a very good communication skill, and both join hands together, you are going to be best in your field. Mark my words, this will be right. 1 year back only I came to Chennai. One and a half years back only I came to Chennai. In this 1.5 years, my dedication, my hard work, my communication skills had made me to bring as an author to this book, made me as a faculty to you people, made me as a speaker in many news channels like Pudhiya Thalamurai, Satyam TV. I have got my own YouTube channels and all these things. I was able to establish myself in Chennai, where there's a great competition. I was able to do it just because of my knowledge and my communication, the love which I have in my subject. Okay, so these are my important points in my intro class. Okay, so I will just go through any of your questions. Okay. Okay, then somebody has asked about the ARDS. I think ARDS is a very big topic to discuss. Lung gets infected. It is an immunological reaction. Okay, especially happening in the lungs because a lot of inflammatory mediators over there. Okay, name of my book is Respiratory System: A Complete Review for Practical Examination. You can RS by RS, RS by RS. My name is Sabrinath Ravichander. Okay, Sabrinath Ravichander. This is the name of the book. Okay, Priya has got a doubt. Which college you studied? Okay, I will say you, I studied my undergraduate from government Dharmapuri Medical College and Hospital, government Dharmapuri Medical College and Hospital. I studied my postgraduate from government Surat Medical College and Hospital, Gujarat. Okay, both are government colleges which I studied. Okay, right. That year I did my MD. Then what's cavity? Cavity, it's we are definitely going to discuss cavity in an exam case in subsequently. Okay, so we will definitely go through it, don't worry. Then where can I get out? I think I answered two doubts I have, sir, which I came to through path exam. What was your doubt? Why is my neural? Okay, right. Okay, fine. I think most of them were happy with the sessions. Okay, okay, all right. Okay, I think no much more questions are there, and I think we can end our. Could again tell why sputum comes in parenchyma. As I said, parenchymal and airway. Okay, they both are the places where the sputum production takes place because many in the parenchymal lung disease, especially active infective like tuberculosis or infections like pneumonia, they all causes necrosis. As a result, there is sloughing of the tissues, and our immunological mediators goes there and form together and forms an sputum. Okay, so they got a direct access to the airway, and through the airway we are expectorating it out. So the problem should be either in the airway or in the parenchyma. It cannot be in the pleura. Okay, so when will be the next session? I don't know. We have to ask to the IMA team. Okay, right. Okay, I think we will take a leave. Even my mouth is also paining. Okay, after 1.5 hours of talk. Okay, hope we will meet you all guys very soon. Thank you for the at least these 200 students. I think there are thousands of students in across Tamil Nadu, but apart the in that only 200 are ready to come and attend the session. What to do when it is free? Nobody will like it, but when we are ready to pay some 40,000 or 30,000 to Marrow app, who's taking 40,000 and not talking even half the concepts what we talk, people are ready to buy. Correct? Okay, but when we are talking taking a session in the free, nobody is going to see that much. That is the thing. Okay, anyway, bye everybody. Apurva also thank you Apurva. Okay, meet you next time. Okay, fine, bye everybody, thank you. I will take a leave.